colleagues, it's such a pleasure that you're all joining today. I'm sorry that we are unable to see each other. As a background, let me say that on April 18th and 19th, 2020, we were supposed to hold the Medanta Cardiology Today and Tomorrow conference, which we do every year. And this Best of Cardiology series was supposed to have the 9th season this year. But because of unprecedented circumstances, I and Dr. Manish Bansal, we decided that we should go digital now, because one doesn't know when there will be a face-to-face meeting. Interestingly, the meeting this time, and many of you may have actually received the brochures also, the theme was unraveling the complex clinical cardiovascular conundrum. And we have come a full circle, because in this COVID pandemic, we are actually in a clinical cardiovascular conundrum. So welcome everyone to the World Heart Day 2020 and our Medanta Cardiology Today and Tomorrow first digital meeting. The theme this year set by the World Heart Federation is Use Heart to Beat Cardiovascular Disease. You remember last year they said my heart, your heart. This time it's gone even further to say how can we help use heart to help beat cardiovascular disease. With these brief words, I would say that the times are unprecedented really, and there is stress everywhere, but there is also positivity everywhere. Look at doctors, COVID or non-COVID, people are on their jobs, people have not slept nights, people are looking after their specialties, taking full care about for themselves, their family, their staff, and also their patients. With these brief words, colleagues, let me introduce you to Dr. H.K. Chopra, my friend, colleague, and actually brother. We have traveled together in the field of cardiology for the last 35 years. He will chair this session, and Dr. Manish Bansal, whom we've been together for so many years, planning and actually doing things in the Medanta Heart Institute, where it makes me feel proud that I have good friends, good colleagues who stood by in the times of need. COVID-19 and myocardium. From myocardial injury to healing, Dr. Manish Bansal has very succinctly defined our problems as cardiologists, problems of the patients as when they come with a cardiac disease, and how do we go forward. So let me take it from a step further. We'll go from there. So the background of coronavirus disease 2019 has already been defined, and it's undoubtedly one of the deadliest pandemics in modern history. And the mode of infection is direct entry of the virus into the cells, and this Dr. Bansal has said very, very clearly. Which is predominant. So the direct entry of the virus into cells via human ACE2 receptors, which is predominantly in lungs but also throughout the cardiovascular system. This slide has been shown many, many times, but if you look at it, it is this ACE2 which actually shown is the initial entry of severe acute respiratory coronavirus into the cells, primarily ACE2 pneumocytes, after binding to its functional receptor, angiotensin converting enzyme 2. So this is the real this thing with which the virus actually enters into the lungs. After endocytosis of the viral complex, surface ACE2 is further down-regulated, resulting in unopposed angiotensin 2 accumulation. This is the key step in actually the virus getting into the lungs. Now, SARS-CoV-2 causing COVID-19 is the 7th coronavirus disease known to infect humans, in which 3 coronavirus outbreaks have been reported already in the 21st century. 2003 was SARS-CoV, which caused 774 deaths. Then 2012 we have MERS-CoV, and then 2019 has superseded the death toll of SARS and MERS many times over. And if you look at it, it has become, as of today, one of the biggest killers, or number one killer of worldwide. It's number one cause of death worldwide. And the same thing is seen here, shown here. The current situation in India. We started in March, April, and then slowly it built up. The curve is flattening, but the numbers have been huge. It is important to understand, to realize the stages of COVID-19 infection, because what may appear as stage 1 to be early infection in which there are mild constitutional symptoms may definitely very quickly deteriorate to 2A and 2B, and then into stage 3, which is the hyperinflammation phase. The point is that many of the people who have very few symptoms to begin with actually have, and with time course, shortness of breath and ARDS, and may actually not actually make it. So cardiovascular, cardiovascular complications are the most common complications among hospitalized patients with COVID-19 and are associated with higher risk of in-hospital mortality. So myocardial injury is 7.2 to 40.9%, and strokes, acute heart failure, as Dr. Bansal has already said, pose a huge problem, and some of these things may not be realized actually. We've seen patients going away and then come back with acute heart failure or with myocardial injury. So what is myocardial injury? The 4th universal definition of myocardial infarction defines myocardial injuries as a TN concentration above the 99th percentile of URL, but it can be, it's acute injury or chronic injury as a result of mismatch between supply and demand. It can be acute non-ischemic myocardial injury, myocarditis, direct myocardial myocyte damage, sepsis, or stress cardiomyopathy. This picture actually depicts something very, very clearly, that those who have mild disease, those who have moderate disease, and those who have severe disease, you can see actually the incidence of myocardial injury in COVID-19 as gradually increasing, and those who have higher degrees, or those who are intubated, have higher chances of getting actually had myocardial injury. And the possible mechanisms of myocardial injury are manifold, but very clearly, if you look at hypoxia, metabolic demands, these include the oxygen supply and demand mismatch. This is actually what we call as type 2 diabetes, type 2 myocardial infarction. Oxygen supply demand mismatch, and this can cause an increase of HS troponin, and this can cause myocardial injury. So myocardial injury is totally separate from myocardial infarction, and that the 4th universal definition of MI has very clearly demonstrated. But here comes the catch, that in many patients the epicardial plaque may be there in the patient already. It's just a plaque, but as a result of hypoxia, as a result of metabolic demands being high, as a result of continuing tachycardia, they may also actually have a myocardial infarction, and that is demonstrated, and that is shown here in one of those patients who had a plaque rupture and had a type 1 myocardial infarction. So these are two things that we have to keep in mind, that we are seeing myocardial injury by far and large, which is an oxygen supply demand mismatch, but we can also have an actual infarct as a result of this disease. So potential treatment strategies to minimize myocardial injury in hospitalized patients, or what I thought was that truly direct invasion through ACE2, we can have viral protein neutralizing antibodies, ACE2 blocking antibodies, doesn't seem like so. Hypoxia and ischemic injury, oxygen therapy, hemodynamic support. Abnormal coagulation and microcirculatory disturbances, you can have prophylactic anticoagulation, which people do anyway, and there can be a cytokine storm. So if you look at it, myocardial injury is not limited to just severe and critical patients. That is one question. Secondly, what are the long-term implications of this myocardial injury? Actually, one doesn't know. And are you healed once you have recovered? And that truly is what I have to speak about. COVID-19 and myocardium, from myocardial injury to healing. This study of ours of 30 patients, initial 30 patients, our ongoing study of patients recovered from COVID-19 at Medanta Heart Institute, patients who presented back to hospital with cardiac symptoms were 30. Patients were aged between 27 and 70. 23% of the patients were had past history of cardiovascular disease prior to COVID-19. So many of the patients actually had no disease, no cardiovascular disease. One of the things that I found in our patients, and we are analyzing a far bigger data, is palpitations are very common, sinus tachycardia is very common, chest pains, dyspnea, of course, and undue fatigue. These are some of the presenting symptoms in these patients. When they came back, the patient underwent a complete cardiac evaluation, electrocardiography, and we did use 2D echo with GLS. And many of the patients, and I'll show you one patient at least, where the GLS was abnormal. So, and they had Holter monitoring as and when required. They had complete troponin levels, height sensitive troponin levels, along with complete blood counts, kidney, liver function tests, and of course, chest x-rays. So our preliminary results show that a large majority had actually normal ECGs. Sinus tachycardia was seen in 20%. Supraventricular tachycardias were also seen, as also sinus bradycardia referred to by Dr. Manish Bansal. Echocardiographic changes and abnormalities in the remaining patients, we found a global LV dysfunction in 2%, normal LVEF with reduced GLS. This is emerging as one of the problems that may affect these patients later, but if we have a handle of this now, we can track them with far more sincerity. And of course, they can have normal LV systolic fraction. So what I have for you is a mixed bag. There are people who keep finding me, even on the video, that they have increased heart rates, they are not feeling well, their tachycardias, their echocardiographic evaluation is actually normal. Herein I'm showing you a patient who studied 2 years old, a COVID recovered patient. She had no past cardiac injury or history, but she continuously complained of palpitations, and with Holter we defined that as sinus tachycardia. She had dyspnea, and you can see here very clearly that even though her global left ventricular function was normal, she actually had impaired global longitudinal strain, which was at -15. What are the possible implications of this? Only time will tell, because this disease is still an enigma. But definitely more and more people are reporting problems in subendocardium as picked up by global longitudinal strain. So although the most virulent manifestations of COVID-19 is ARDS, many worldwide reports have demonstrated cardiac injury through elevation in troponin concentrations. Again, I repeat, every troponin concentration is not a myocardial infarction. Most likely cardiac injury, myocardial injury, or a type 2 MI. And of course, there are still large gaps in our current understanding of the underlying mechanisms by which this virus affects cardiovascular system and how such involvement may alter clinical outcomes, and they may alter clinical outcomes greatly over a period of time. So Jack carried an article which was based on Mount Sinai hospitals in all across the state of New York, and they asked 3 unanswered questions. What is the range of troponin levels elevation across different populations based on history of CVD compared to those without CVD, and whether these troponin elevations represent infarction or injury, and what is the impact of myocardial injury in the context of the COVID infections. And this is what they came up with, and this is what we are seeing as well, that the blue are the hospitalization, D is the discharge, M is the mortality, and the mortality successively increases if the initial myocardial injury, if troponin levels are high. So does the troponin give you a handle of what is going to happen? Possibly. Troponins, 2D echocardiography, global longitudinal strain, all these can tell us. But this study was good in the sense that they said what happens to people whose troponin levels are between less than 0.03, between 0.03 to 0.09, and above 0.09, the mortality was the highest. And same thing here, even milder forms of myocardial injury were associated with higher risk of death and less frequent discharge than troponin levels in the reference range. So these are important things that I think all over the world, cardiologists are getting into the mainstream of COVID treatment and trying to risk stratify patients to see how they can help. So COVID-19 therefore causes systemic inflammation with varying presentations of cardiac involvement. This is important, varying presentations of cardiac involvement. Although troponin elevation above 99th percentile is considered the central marker of myocardial injury, only few patients met this criteria for myocardial infarction as the fourth universal definition. And this is one definition from, this is one central diagram from the same article, and again the outcomes are listed here. If you look at the mechanisms of myocardial injury, inflammation, cytokine storm, micro and microthrombi, direct viral invasions have been postulated. I think one of the things that's very important is actually supply-demand imbalance, and that actually causes type 2 kind of a myocardial injury. So myocardial injury is prevalent, generally at low levels among patients with acute COVID-19 and is associated with worse outcomes. History of CVD was associated with myocardial injury in the setting of COVID-19 infections, and the results of this study suggest abnormal troponin concentrations. We are finding results almost akin to these findings. So when we look at, so this is one part, the myocardial injury part, but when we look at COVID patients who go home and then talk to you on the video, several things have come out, and which I would like to deal with. The healing part: breathlessness, excessive tiredness, muscle aches, fever, palpitations I'm finding very commonly, chest discomfort, headaches, confusion, low moods, and insomnia. Many of these symptoms are echoed across by many other cardiologists who feel that patients have inordinate tachycardias. Healing post-recovery, I really don't know. But unlike conditions that have been known for decades, COVID-19 still stands as an enigma, and so all of us are learning that how we can help our patients heal better. What are the role of medications in healing? I've used beta blockers, and where the blood pressure didn't permit, I've used ivabradine, because in those patients who continuously complained of tachycardia, ACE, ARBs and early, if the patients were taking, we have not stopped them. Statins could have helped, and of course there is a growing body of thought that says that omega-3 fatty acids can actually help. So all patients are advised to continue their previous medications in adequate doses with regular home monitoring of blood pressure and heart rate. Actually, at home today, you can actually have a heart station with a BP instrument, a ECG, and you can have a pulse ox, which will tell you oximetry and the heart rate. These things are important to treat our patients at home because they're afraid to come. The role of diet in healing is immense. Food items rich in minerals, omega-3 fatty acids, manganese and antioxidants are supposed to be good. So green leafy vegetables, whole grains, whole wheats, oats, barley, fish and fish oil, garlic, and especially I would like to say that walnuts can be used because they is the only nut which has significantly higher levels of omega-3 and also alpha-linolenic acid, the ALA, which others don't seem to have, because the disease is still unfurling, it's still unraveling. So we really don't know where it will go. So wherever we can help the patients in a non-invasive fashion by diets and yoga, we should do that. And omega-3 fatty acids, the ALA, walnuts are unique among them. They are primarily comprised of polyunsaturated fatty acids and then only nut that's significantly high in omega-3. So the thing is that diet will play a very major role. Ancillary medication plays a definite role in this condition, and many of us follow the Predimed diet, and in the Predimed diets, Mediterranean diet are supplemented with mixed nuts, but 50% are walnuts, and the walnuts are the ones which give us a lot of ALA and things like that, which are helpful in this condition. Walnuts and heart health have been known for a while. Since 1933, researchers have been investigating how eating walnuts positively affects various heart health biomarkers and risk markers. And in this condition, where patients are sitting at home, they do need something, and walnuts and heart health has been known for a while. Though this is not the primary thing that I have to speak about, but definitely I would like to re-emphasize the use of good diet, a wholesome diet, and walnuts would help. Role of exercise, you have to be very, very specific here that COVID-19 triggers an intense inflammatory reaction. So recovered patients are recommended to stay active, but you will have to see that exercise, you will have to examine them or at least look at their heart rates and blood pressure before you actually ask them to exercise in any way or form. But with patients with no history of cardiac injury, they should embrace a gradual return to physical activity before they go back to their pre-COVID-19 workouts. That is very, very clear. So there is of course role of mental health also in healing. Healing thoughts, positive thinking. Yoga is an extremely good thing at this point. Breathing exercises and mind-body healing. And who better than Dr. Chopra to say a few words about these things. So I would end by saying that I think I've raised more queries than actually answers. But certainly I believe COVID-19 is not just a respiratory disease. I think myocardial injury is common in COVID-19 and may facilitate risk stratification of many patients, as has been done in at least 2 studies. Myocardial injury and cardiac complications are persisting in covered patients, and we'll have to see. We are there for long haul. We'll observe these patients over a long period of time and then come up with some guidelines. A complete cardiac checkup is advised for all survivors before they rejoin their pre-COVID schedule, because early diagnosis and proactive action can reduce or halt the inflammatory damage. How long the effects are likely to persist remains to be determined and needs further studies. So I would end by saying that the process of healing does not end when the wounds are no longer visible. Thank you, Dr. Chopra. Thank you, Dr. Bansal. Thank you, ladies and gentlemen, for your patient hearing. I know I raised more questions than answers, but then all of you are also seeing patients of this kind, and maybe we can all work together to come to a common consensus. Thank you very much.